I welcome you all to the most awaited shortlisted presentation on evidence-based practices, patient safety, and staff safety. I take immense pleasure in welcoming Ms. Madhukari Ray, Vice President, West Bengal Chapter, Annie, and the jury members to facilitate the presentation.
Good afternoon. Myself, Captain Madhukari Ray. I am the Nursing Director of Apollo Multispeciality Hospitals, Kolkata, Eastern Region. And here I've come to talk about track 5, where we are going to have best paper presentations on evidence-based practices and patient and staff safety. So evidence-based practice is a problem-solving approach in which the best available and useful evidence is used by integrating research evidence, clinical expertise, patient values, and preferences to improve health outcomes, service quality, patient safety, clinical effectiveness, and employee performances. So we have 5 distinct methods and steps by which we can really present evidence-based practices in a structured manner, which are access, ask, appraise, apply, and audit. So here I would like to mention that we have all across the country almost 25 participants who have done their paper presentations, and it was difficult to shortlist, and we have finally shortlisted 5 candidates for the best 2 paper presentations on evidence-based practices and 3 best paper presentations on nurse-led quality improvement projects. And now I would like to invite our jury members, and I would like to take that opportunity to introduce my jury members for this selection. My first jury member is Dr. Anita Sharma. She is a clinical microbiologist and infection prevention and control. She is presently working in Fortis Hospital, Mohali, a tertiary care NABL, NABH, and JCI accredited corporate hospital. She is heading the Department of Laboratory Medicine and the Infection Control Program of the hospital. She is engaged and collaborated with the community and governmental authorities on diseases of public health importance. I have my second jury member. She is Binamma Kuriam. She is the Senior Manager Quality, St. John's Medical College Hospital, Bangalore. My third jury member, I'm very happy to introduce Dr. Unmana Borgain, who is the founder EC member and also the president Annie Northeast chapter. She is the principal of Asian Institute of Nursing Education and Dean Faculty of Nursing, Srimanta Shankara Devya, University of Health Sciences, Government of Assam. My fourth jury member is Dr. Rosalind Rachel. She is also the EC member and chair, Annie Education Committee. She is also working as principal in Madras Medical Mission College of Nursing. My fifth jury member is Dr. Anu Kaushik. She is the Annie EC member and nursing director, Cloud9 Hospitals. She has done her post-graduation in nursing from Delhi University and PhD in nursing from Maharishi Markandeya University. So I would welcome all my jury members and I give special thanks to my external jury members, Dr. Anita Sharma and Dr. Binamma Kurian, to give their valuable time to select our best paper presentations. And now over to my jury members. Please start your time to select the best paper presentations. Thank you. Good afternoon, everyone. So my first paper presentation starts. The topic is effectiveness of acupressure or on improving the quality of sleep among cancer patients. And it will be presented by Ms. Manjula Chandu, nursing educator, HCG Hospital Care Unit, Bangalore. Can we have Ms. Manjula Chandu here?
Namaste, ma'am. Namaste to all. My studies on effectiveness of acupressure on improving the quality of sleep among cancer patients in HCG cancer patients, ma'am. regarding that, I need to proceed.
Very good. Yes, you finished. While sitting there only, I finished. Now anything more?
Namaste, one and all. This is Ashwini R, the nurse educator of HCG KR Unit, Bangalore. I take this privilege on behalf of my team to present our study on evaluating the effectiveness of acupressure on improving the quality of sleep among cancer patients. To begin, sleep is very important for overall health of every individual, and all of us love to sleep. Some even call it as a hobby. And most often, sleep was ignored by the medical industry in the past. But now, it's zoomed as a most integral part of healthcare. Anyone with less than 6 or 7 hours of sleep every night are at high risk for developing any kind of disease. In our study, we found that the sleep of our cancer patients accounts for 30 to 75% of the disease process, and most of the time it's unaddressed and unrecognized. Pittsburgh Sleep Quality Index helped us to understand the relationship between good health and sleep. Our problem statement is a study to evaluate the effectiveness of acupressure on improving the quality of sleep among cancer patients. And the rationale behind the study was during our regular rounds, we found our patients looking dull, lethargic, anxious, stressed, frustrated, irritated, reduced daily activity, which was directly or indirectly due to poor quality or lack of sleep. Hence, we decided and aimed to assess the quality of sleep and to carry out specific sleep improving interventions as acupressure on improving the quality of sleep among cancer patients. Let me now tell you about the inclusive and exclusive criteria. Our sample size was 60, and we have included patients between the age group of 35 to 50 years and those who were hospitalized for more than 8 to 10 days approximately. We had no gender bias in selecting our samples, and all types of cancer patients were included. We have excluded certain patients who were critically ill, who were on sleeping medication, and those who were not willing to participate. This slide speaks about modified conceptual framework model, which shows the different stressors, our interventions, our reconstitution, that is, where the patients were subjected to 7 days of acupressure for 3 minutes before bedtime. The acupressure points includes behind the ears, wrist, and calf muscles. Here, this model also depicts and speaks about 3 different levels of preventions, that is primary prevention, secondary prevention, and tertiary prevention. In this slide depicts a pre-data based on different parameters. Here, I am going to speak about the pre-data and the post-data. On comparing the pre-data and post-data, 83.33% of our patient had good sleep. Another 16.67% had fairly good sleep, and none reported poor sleep after our acupressure intervention. This shows acupressure really works on improving the sleep of our patients. To conclude, our interventions of acupressures have definitely improved the sleep of our patients, and hence it will be regularized on all our patients as part of nursing intervention to improve our clients' sleep. I take this time to thank the jury members for selecting our study, and I also extend my heartfelt thanks to the management, to our corporate team of nursing, and last but not the least, my team who worked along with this project, namely Ms. Sampa, the nurse manager, Ms. Manjula PM, the nursing officer, Ms. Lakshmi A, our chief of nursing, and myself, Ms. Ashwini R, working as a nurse educator. I thank one and all for giving us this opportunity to present our study. Thank you.
Thank you. I go to my next speaker, who is Ruby Ravichandran, Deputy Nursing Superintendent, Kaveri Specialty Hospital, Cantonment, Trichy, Tamil Nadu. She is going to talk on increase the rate of exclusive breastfeeding. Before that, I would like to request Dr. Unmana, one of my jury members, to ask question if you have any, to Ms. Manjula. Dr. Unmana, please.
Yeah,
Can
probably.
anyone from the jury?
Yeah.
Yeah, Dr. Rachel, yeah.
Relate which was disturbing you from collecting the data. Was the clients cooperative in getting the study done?
Namaste, ma'am. Namaste to all to giving this opportunity. So when I go to the assess the patient, I assessed all of the patients. In that among that, so overall willing to cooperate means we are willing to give the details about their sleep disorders or sleep disturbance. Those we have selected, ma'am. So in that 60 patient I have selected for the study. So who is inclusive criteria? Who is having an inclusive criteria?
Okay, sleep is something which people don't get satisfied how much ever they sleep. So, how did you exactly? What are some of the challenges you faced when you are doing this assessment?
First and most thing, people will not give a proper details about that why the people they are getting a disturbance of sleep. What is the frequent they're keep getting admit in the hospital for the sleep disturbance, and they are most taking prefer for the medication. They don't want to disclose that why they are getting a sleep disturbance. So when we go on depth and we are raising a questions, so repeatedly we assess the patient. Based on that only they come to the conclusion and they give us the details. Based on that only we have selected and we have introduced the acupressure, so which can be improve their quality of life by good sleep.
Thank you, Manjula, for answering the question. Thank you.
Thank you, ma'am. Thank you so much.
Thanks, Manjula. Can we go ahead with our second presentation, please?
Yeah, please go ahead.
Thank you,
Thank
ma'am.
you.
Vanakkam. Greetings from Kaveri Hospital Cantonment, Trichy, Tamil Nadu. We are from neonatal ICU and our NICU is 30-bedded unit. We have taken QC under evidence-based management and the topic taken for this presentation is to increase the rate of exclusive breastfeeding. Why this topic? A small intro. On the observation, weight of the preterm babies was not up to the mark due to formula feed intake, which resulted in dissatisfaction of the parents and also got hike in the expenditure of formula feed. Eventually, hospital stay prolonged as well, which caused stress and anxiety for the parents. So our focus turned on to increase the breastfeeding rate. Hence we started this QC project.
Our main problem is decrease in the rate of exclusive breastfeeding. Due to this prime difficulty, we faced other added issues like increased usage of formula feed, slow in gaining baby's weight, dissatisfaction of parents, increased cost on formula feed, delayed discharge. Our aims and objectives to achieve these goals are to promote exclusive breastfeeding, to strengthen lactation counseling, to adhere to baby-friendly protocol, to reduce the patient cost on formula feed, and also to reduce the length of hospital stay. Project duration. We have started this project in July 2020 and ended in December 2020.
When we brainstormed with the team, we identified 12 causes and categorized those causes into significant and non-significant. The causes are lack of knowledge on breastfeeding significant, lack of knowledge on food which increases breastfeeding significant, following old traditional method non-significant, cultural belief significant, inadequate antenatal counseling significant, lack of knowledge on express breast milk significant, lack of motivation significant, stress significant, lack of knowledge on breast pump technique non-significant. Focusing the brainstorming causes under the cause and effect diagram using fishbone tool, causes were analyzed under the category of man, method and material.
Before implementing the plan, the data what we have collected for 3 months period as displayed in the tabular column. In July 2020, formula feed was 25 and usage of EBM 5. In August 2020, 33 and 8. September 38 and 9. The data of formula feed was alarming. We had to set an action plan, which was initiation of exclusive lactation counseling, distribution breastfeeding booklets, initiation of displaying breastfeeding promotional videos. Taking these action plan into an account, we started implementing action points in our field area. The first point was adaptation on baby-friendly policy. We strictly adhere to the 10 steps baby-friendly hospital initiative. Created a designation nurse lactation counselor as previously we didn't have exclusive lactation counselor, and we have defined and trained the counselor intensively. Hotline number created for the counselors through which mothers can contact 24/7, and also the hotline number is being given in discharge summaries. We have created in-house video and breastfeeding pamphlets which is being used every day during lactation counseling for all postnatal mothers. Lactation counselor will review the mothers on daily basis and will give focused counseling based on the demand of the babies.
After implementing all these action points, we found out a tremendous changes which showed significant positive outcome which reflected on the data displayed. Formula feed drastically decreased, breastfeeding and usage of EBM increased. We also started receiving hotline queries where the lactation counselor answered all the questions, which helped to clarify the doubts as well as motivated the mothers.
Through this project, we attained tangible and intangible benefits. The tangible benefits are cost saving, early discharge, and intangible benefits are patient satisfaction and delight, absolute gratification of the healthcare workers. Outcome of this study, preterm babies attained daily weight gain and able to discharge them early. We reduced length of stay in the hospital and also decreased cost of hospital and formula feed expenditure, which obviously offer patient satisfaction and delight, through which we attained vision and mission of our hospital.
Recommendation. This QC has given a successful outcome. Any other hospital can also adopt this process for early recovery of babies. Thank you.
Thanks, Miss Ruby. Can I ask my one of the jury members, Miss Binamma, to ask any questions if you want?
Yeah, I have two questions. Number one, what is the steps you have taken in antenatal care itself? You were talking about how training you are giving to the mothers and all. So, what steps you have taken for antenatal? First question. Second question, what is that timing you are given for emotional bonding or anything? How much time you are giving to the parents on this and to the mother? Hello, can you hear me?
Yeah,
Ma'am,
you are audible.
can you hear me, ma'am?
You are audible,
No,
Ruby.
yeah,
Hello?
I can
Ma'am,
hear.
can you hear me?
Yeah, we can
Yes,
hear.
yes.
Go ahead
Yes.
and answer.
Ma'am, can you hear me?
Yes, yes,
Yes,
go
we
Yes,
ahead
can
and
hear
yes.
you.
answer.
Ma'am, before antenatal counseling was only given by the doctors, ma'am. They had only limited time to give on lactation aspect. So after this lactation counselor, our OP time we cover 1 to 2 for the mothers, ma'am. So we cover the antenatal mothers. We prepare them for the exclusive breastfeeding.
Okay. What is the time you have given? At least how many months exclusive breastfeeding are you training that to the parents?
Yes, ma'am. Yes, ma'am. Exclusive breastfeeding for 6 months. This problem we faced for the inborn mothers, ma'am, who are
Okay.
delivering a preterm babies. So we have a good rapport with the mothers. Our counseling will. Ma'am, am I audible?
Yes.
Yes, please. Yes, please
Please
proceed.
carry on. Carry on, Ruby.
So our counseling is a focused counseling on babies who are not gaining the weight. So we give at least half an hour time for the mothers. We spend with them, we teach them, and we see the assessment also, ma'am.
Okay. So I think Binama, that is enough for your question that you have asked for. Is that satisfying answer?
Okay, ma'am. Let us continue. Thank you.
Fine. So with this, we end with evidence-based practices. Now we will move on to quality improvement projects. We have three presenters for that. And my first presenter is on medication in 60 minutes, which will be presented by Jasing David Selvaraj, who is the Chief of Nursing Services, Shayadri Super Speciality Hospitals, Deccan, Maharashtra. Can I have the presentation, please?
Namaste. Myself, David Selvaraj. I work as a Chief of Nursing Services at Sayadri Hospital, Deccan, Pune. I'm very proud and glad to be a member of ANI and to present my project on expedition of medication administration within 60 minutes of patient admission. I would like to take you all to the flow of content where I'll be sharing with you all the importance of drug administration on time, need for the project, nursing challenges, key stakeholders, intervention steps taken, data analysis, outcome of the project, must follow rules to sustain, and conclusion. We know how important it is to administer drug on time. It is said taking medicine on time as prescribed is essential to make sure your body has an effective amount of drug at all times. If not, this can cause the disease to develop a resistance to the medicine or simply prolong the amount of time it takes to feel better. As per the CDC guidelines, it is said 50% of disease treatment failure is because the medications are not administered on time. As per the ISMP guideline, it said medications are supposed to be administered 30 to 60 minutes before or after the scheduled time, but not later. What brought us to this project? Negative feedbacks and complaints from patients and relatives of non-administration of drugs even after hours of admission. Unsatisfied and unhappy consultant. Even it was our concern the patients were not receiving treatment on time after diagnosis. A pre-analytic data study was done where we found in the month of April, May and June, almost on an average of 20 patients per month had complained that they were not receiving medicine on time. A multidisciplinary meet was held where the unit head, functional head, especially the pharmacist, and CMO and the consultant representative were present. A brainstorming exercise was done based on the problem. Analysis was done and we came to a solution. What was identified was that there was a delay in drug indent by the nurses, ineffective drug delivery method, gradual increase in the complexity of care, no timely follow-up by the nurses. The key stakeholders in the project were the nursing department, pharmacy department, and the administration. The intervention steps taken by the nursing, administration, and pharmacy, which is the key to this project. Awareness created among the nursing staff regarding the severity of the issue and the commencement of the new initiative. Amicable nurse-patient ratio was worked out with senior coverage. Alerts were received by the nursing supervisor of the new admission, which means an SMS was triggered to their mobile. Quick indent of medication as soon as the doctors were putting the order. Inform the pharmacy SPOC. Visit by the nursing supervisor within 30 minutes to check the status. Ensure to administer medication within 60 minutes of order. Steps taken by the administration. The areas covered were only ward. It was applicable to all new admission. Provisions were made to activate the SMS alert to the on-duty supervisor mobile. Pharmacy SPOC was identified for each shift only to dispatch new admission medication. They were supposed to utilize either the pneumatic chute or the porter system. Each shift, the information regarding the details of the SPOC was shared in the common WhatsApp group as well as displayed in the nursing boardroom. The data analysis, as I said earlier, in the month of April, May and June, we had almost 20 complaints every month. And in the month of July, we did the implementation of the project. The plan was implemented. And later on, there was a drastic change which we can see in the post-project data. Now, later on from August, the number of complaints came down to 1, 2, and 3. And when we did the root cause analysis, we found that those reasons are valid because some of the patients were no credit and they were getting the medicines late. And in some cases, the nurses were not able to assess the vein and they has to wait for the anesthetist to come and put the cannulation. Outcome of the project: escalation in positive patient experience, improved consultant satisfaction, reduced customer complaints, increased work satisfaction of the staff, ensured smooth flow between the pharmacy and the nursing staff, and enhanced treatment outcome. Way forward: staff nurses must ensure that they attend the doctor's round and indent medications immediately. Contact or alert a pharmacy SPOC once the drug is being indented. Supervisors must visit and revisit for all new admissions. Ensure first dose of medication is administered on time. Pharmacy SPOC person name to be displayed in the notice board in the nursing room. Monthly data collection, RC to be done if there is any non-compliance. Effective corrective and preventive actions to be taken and reinforce the training. To my conclusion, I'd like to say that medication administration is an extremely important component of disease management. Within medication administration, the patient expects the right medication in the right dose to be at the right time by the right route. Right time, which is clearly identified as a vital aspect of the medication administration process, should therefore be clearly defined as well as achievable by the care team. I would like to thank once again the Annie for giving me this opportunity to share my project. Thank you.
Thanks, Jaising David. Uh, can I ask Dr. Anita from the jury members to ask questions if you feel anything?
Yeah, thank you, Manny, and thank you, David, for the wonderful presentation. I think the topic that you've chosen is very, very important and relevant because this is one area of concern in most of the hospitals. So my one
Yes.
question to you is that you tried many steps here, you tried many things. Of course, it was a multidisciplinary and multimodal kind of a strategy that you looked into. But could you identify one or two key steps that could bring about this change and improve your patient satisfaction?
Yes, ma'am. There were two key things. One is like to trigger a message to the supervisor so that during the round they could take a follow up and to make sure that the patients are getting the medicines on time as per the project. And the second most important was to alert the pharmacy. And the SPOC was being identified so that the message was being so that our nurses they can contact the SPOC pharmacy and they could deliver the medicine on time. Earlier, there was a delay in that because it was a common call. Now, the nurses were aware whom to call, and that mobile number was being displayed in every nurse's station. So that helped us to achieve this project.
So you feel that it was a better communication. This was a manual call or
Yeah.
was it some system generated?
Sorry, ma'am.
Was it a manual call or was it a system generated support that you got in this?
It was a
You
manual
call.
call when. Yeah,
Okay.
because the nurses after the intern they'll have to call the SPOC person. We have a short code
Okay.
internal telecom, and
Okay.
the person is to deliver the medications immediately.
Okay. Sure. And one last thing, did it include the vital drugs as well?
Yes, yes, everything. Even the stat
Everything.
drugs also we used to give on time because this helped us to do that also well.
And you didn't include your ICUs. Do you think it is escalable to the ICUs as well, this project?
Yeah, we not included IC because being a critical care, even our emergency and critical care team, once the order is put, we normally get medications on an urgent basis because we have a time frame for the ICU drugs to be delivered on time. So pharmacy has a target for set target for that. So they deliver on time.
Okay. Thank you, David. Thank you very much for a
Thank you, ma'am.
wonderfully
Thank you so much.
presented.
Thank you. Going ahead in future, I feel that if it like manual interfaces can be reduced and we can have more on online system, then we can reduce further. I think he will be benefited much more then.
Yeah, we'll work out
Then
on that.
yeah, my next speaker is Miss Josephine Cyril. She is the Chief Nursing Officer, Sir Gangaram Hospital, New Delhi, and she is going to enlighten us on oxygen utilization.
Good afternoon. Greetings from Sir Gangaram Hospital, New Delhi. Here we are going to present a study on oxygen utilization, and this study is led by the nursing team, initiated by the nursing team, and we had presented this study to the management and that was highly appreciated. The objectives we set for this study was to study the use of oxygen therapy on the medical wards and the critical care areas. And also we wanted to see the oxygen prescription and the implementation, to check on the compliance to oxygen therapy by our patients, to educate our nurses, ANMs, and nurse assistants the importance of strict compliance to oxygen therapy, to educate our patients and family, and to minimize wastage and to maintain infection control standards. The team consists of our nursing supervisors, infection control nurses, nurse educators, in charges, ANS, DNS, CNO, biomedical engineers, gas plant engineers, and deputy medical superintendent. The period was from Jan to July 2021. We had prepared a checklist, and this checklist consists of all the important points which was required at that time during the pandemic when we had severe shortage of resources, especially oxygen, and the situation was very alarming. And we thought this was the right time to initiate this study to improve the situation. So this was the checklist we had prepared, and based on the checklist, we had done the audit, and 391 samples collected from critical care area and 293 samples from non-critical area. So if you look at the non-compliances in critical area, we had 28 non-compliances, and in the wards 45. And in the critical areas, the main observations were the sterile water not sufficient in 11 situations, and mostly the oxygen wastage was in 12 cases, and oxygen leakage was 5 cases. There was date mentioned on each humidifier. In non-critical areas, sterile water was not sufficient in 22 cases, and oxygen wastage was in 6 cases, and oxygen leakage was in 57 cases, and date was not mentioned on 2 cases. So if you look at a consolidated data, you can see the total observations when you sum up. The sterile water which was put in the humidifier was not adequate in 33 cases, and oxygen wastage was in 18, and oxygen leakage 20, and the date not mentioned in 2 cases. So we done an RCA, and if you look at the patient factors, those days you can understand the situation was very alarming. Too many patients and less resources. So too many patients on oxygen therapy, and the awareness was not there. Unwilling to use oxygen concentrator where it can be used, patients were not agreeing to it, and lack of patient participation. When it comes to nursing officers and doctors, too many patients and inadequate nurse-patient ratio and resource constraint. When it comes to education and our process, lack of awareness on importance of oxygen utilization, improper usage of products, equipment was damaged, and there was gaps in the infection control practices. Environment, inadequate cleaning, lack of patient support, and resource constraint. So a lot of training was done by our nurse educators. You can see in the picture, our nurse educators are training group of nurses during the pandemic time on usage of oxygen concentrators. And we have taken the training attendance in each case. The corrective and preventive action we introduced, we felt the need, and we made it happen. Training given on oxygen therapy, daily audit by the nursing supervisors, ICNs looked upon all the infection control compliance, coordination with the biomedical engineers and gas plant employees, and proactive approach to minimize the wastage, and regular check of oxygen outlets and oxygen cylinders, and demonstration on use of oxygen concentrated for staff and patients. So many of our patients got agreed, and they personally purchased oxygen concentrators, and they got discharged and went home and managed their medical condition at home, and which was further supervised by our home care nurses. So resources made available, management also took interest, and they purchased many oxygen concentrators, which was not there initially. Humidifiers came in stock, more BiPAPs were brought, and more ventilators came into our stock of supply. So the shortage and the resource constraint was seriously looked into. Regular analysis and discussion in nursing quality meeting. This all we discussed in the various meetings, and revision of audit checklist. We revised our audit checklist again, and any alarming situation we escalated to top management. You can see even today we continue with our training on oxygen concentrators, and it is given to each unit, and each unit is provided with 2 to 3 oxygen concentrators. So this is the latest audit we have done between Jan to March, and you can see 291 samples we collected from critical area and 725 samples from non-critical area. And the non-compliances, which was there high in number, not very high, but still high, that has come down to critical area, just 2 observations. And in wards, we had just 4 observations. So the learning points from this audit study was great improvement in staff awareness on oxygen utilization, active participation by nurses, great contribution by infection control nurses. It was a new learning for the nursing team, and customer education has improved compliance to oxygen therapy and prevention of mucormycosis by improved hygiene during oxygen therapy. Involvement of nursing assistants, ANMs have improved to ensure cleanliness of oxygen humidifiers, tubings, etc. And the oxygen wastage preventive measures was realized as everyone's responsibility. The conclusion is this study highlights the need to adopt and evaluate cost-effective measures such as pulse oximetry, oxygen concentrators for our patients and attenders. Regular oxygen clinical audits have improved staff awareness on oxygen therapy. Wastage of oxygen was reduced, and improvement in infection control compliance. Nurses encourage patients to use oxygen concentrator with the consent of physicians in permitted cases, and the audit process will be continued for sustainability. Thank you. 6 में से ज़्यादा है तो reject.
Thank you, Josephine, for lovely presentation. Can I request one of my jury members, Dr. Unmanat, if you have any question, you can please ask.
Yeah, it was a very nice project. Can you hear me, Dr. Madhukari?
Yeah, I can hear you.
Yeah. So seeing the situation of the COVID, the oxygen consumption and utility, we really can appreciate. The project like this will go a long way. Many times the resources we think it is available, just we just use it. So I would like to say, even for this oxygen consumption, even for the acupressure, finally, what is the order for nursing? Like what order will give to nursing, what message that we can incorporate in the patient care. Suppose I'm giving an order, give bed care, give acupressure care for this. And for my question to Josephine will be, what order to make the nurses alert to optimally utilize oxygen and to help the patient to recover as quickly as possible. Directions to nurses for patient care.
Over to you, Josephine.
So good afternoon, everyone. Good afternoon. Am I audible to all?
Yes.
Yes.
We can hear
So,
you.
Yes, Roshni.
thank you, Madhu, and thank you, everyone over there. It was such a wonderful study. So I heard the question from Dr. Unmona. So if you look at nursing involvement, the uh, the the best part of the study was the whole study was led by nursing team, and it was led by nursing team, even though the thought process came from the management, frankly speaking, because it was during the COVID time, and there was so much of that it was such a rare resource, oxygen. There was shortage of supply, there was a resource constraint. So many such cases it happened that there was wastage of oxygen. So the clinicians also noticed that, and at times the prescribed instruction and what is practiced administered wasn't the same. So the management felt, and the clinicians felt, and even the senior nurse leaders felt some kind of check and the implementation of certain good practices have to be in place. That was the reason the study started. And when it comes to nursing, nursing implemented that study. We sat down, and we senior people along with ICNs, deputy medical superintendent, and other senior nursing personnel, few clinicians, we sat down and we thought what should be there to check. So there was an initial study, mentally exercising, putting our thoughts into action, and a proper checklist was made, and a proper team was made. So nurses led the team. Every day that exercise was done, checking in all the areas, and we could find many areas where the practice was wrong, and what was prescribed, what was administered was incorrect. Right infection control practices were not followed, and first of all, most important, the awareness was very poor. Awareness among the junior most, the uh, ANMs, the nurse assistants, to the freshers, the mid-level managers, to the senior most nursing personnel. So it was a learning for everybody. Everyone learned, and everyone understood this is everyone's responsibility. So even today we are continuing that study, and if you make round and you see the practice of oxygen administration, taking care of the equipments, usage of oxygen concentrator, and the confidence at which the nurses educate the patients at the time of discharge in motivating them to use oxygen concentrator, the whole practices have improved to a great level. That is the greatest satisfaction we as
Okay,
nurses
ma'am.
we have, and
Ma'am.
that whole problem came to a standstill. That's it.
Yes, ma'am. Thank you very much. It was a wonderful topic. Just the question, my concern is like, if it is everything is nurse's job, then like it will be difficult maintaining equipments and everything. Anyway, it is a very nice awareness. Thank you. Over to Madhukari.
Thank you. Thank you.
With this, we come to the last topic of quality improvement project. My last presenter is Miss A.S. Dali. She is a nursing direct educator, Fortis Hospital, uh, Kuningam Road, Bangalore. And she is going to present us on reducing fall incident rate in medical surgical ward. Over to Dali, please.
Namaste everyone, my name is Dolly. I'm a nurse educator from Cunningham Road, Fortis. I would like to thank the jury member for shortlisting our QIP. Our QIP reducing fall incident rate in medical surgical ward. Fall, it is one of 6 the international patient safety goal. Being a nurse and nursing team, it is our responsible to prevent fall and maintain the patient safety during hospitalization. The reason behind to choose this QIP, there has been a increased incidence of fall in medical surgical ward despite of fall prevention protocol. We would want to see where is the gap and we want to do the analysis and to improve through this QIP. So we have set a QIP team. Through this QIP team we have done the root cause analysis. The root cause analysis we have listed the problem when and all the gap. The gap when it comes to a nurse, we found that the lack of effective health education when there is a alternative attender, and then poor assessment where the nurse was not captured the history of fall, and then sedation and the drug which will lead into fall, and then delay in attending the call bell by the staff nurse, and lack of effective early rounds even for the vulnerable patient which was found lack, and lack of follow by the fall champion in ward, lack of supervision of compliance to health education, how well the nurse gives health education on fall which was not supervised by the department in charge and concerned supervisors as well. When it comes to housekeeping, we found delay in providing assistive devices due to change of housekeeping. Every day we had 2 days, 3 days once we had a new housekeeping who was not trained regarding the cleaning protocol and all those things. When it comes to patient, yes, they were resistant to use the assistive devices because the effective health education on commode chair bedside assistive was not given by the staff nurse, and refusing to call patients to call elimination assistance during night time. And other problem factor which we have identified is non-availability of caution board, and then visual cues at the bedside was missing, and inadequate devices as well. So with this problem point, we have set a aim to reduce the incidence of fall rate from 1.4 to 0. With this aim, we have done the solution. When it comes to lack of effective health education, we have planned to conducted training how to deliver effective health education on fall as a part of CNE and department training, and we have conducted OSCE on fall risk assessment, how effectively we have to identify the risk assessment, and then we have planned to motivate the nurse to do effective early rounds for vulnerable patients, and then we have identified the dedicated fall champion and dedicated nursing supervisors to this medical surgical ward, and supervision by the senior nurses on compliance of health educations. And then housekeeping, when it comes to housekeeping, the housekeeping supervisors to instructed the housekeeping supervisors, spoken to them, and we have dedicated 3 housekeeping for that particular floor who was trained in everything. And then supervisors, we have instructed the supervisor, nursing supervisors and the department in charges to acknowledge the patient staff's education on fall, and then distribution of fall prevention pamphlet at the time of admission which was not done, which we have started. And the nurses where sensitizes the importance of attending the patient when there is a call bell and potential to fall, and give assisting devices like bedpan, commode chair during the night time, and then refreshing them to use washrooms. And we have told them even if they want to use a washroom, we instructed the nurse to stand outside of the restroom and take back the patient to the bed. These are the things we have instructed them, we have observed them, and we have followed as well. And we have made availability of caution board, visual cues as an assistive devices. With this, our post intervention, yes, we could see a knowledge increased by the staff from 50% to 94, and the documentation was improved in the consequence months. We have chosen the method of plan to study act. With this we have achieved the incidence rate from 1.4 to 0. This is the comparison pre and post. You can see as given in the PPT. So as a conclusion, yes, we have given adequate, relevant and continuous training to an observation given to team of people to adhere the set of process and protocol, which was really beneficial to decreases the incidence and improve the patient satisfaction on health education as well. So as a control measures, we have listed here like effective health education by the staff, and which will be observed by the department supervisor, and clinical rounds, and then effective clinical rounds by the fall champion and nurse educators, fall prevention, fall point prevalence audit monthly once, and fall prevention training for the new joinees as a part of nursing induction, and then OSCE as a part of CNE, and nursing care bundle audit to get the patient satisfaction and to make sure the 5Ps was addressed for the patients, and then training on safety measures for vulnerable patient as a part of functional training, and in place of IPSG goals, and fall prevention pamphlets to for all the patient at the time of admission itself. So with this control measures, yes, we could sustain our incidence rate, preventing the incidents in medical surgical ward. Thank you everyone. Together we can achieve even more. Thank you.
Thanks, Dalip, for your lovely presentation. Can I ask Dr. Anu Kaushik, one of my jury members, to ask questions to her?
Yes, thank you, ma'am. Delhi, congratulations, a very well chosen topic indeed, and it's very heartening to see that you've been able to sustain, fall to zero, which is like I would really say kind of unheard, and and that too in a medical surgical department. So
Thank you,
coming
ma'am.
to some of the initiatives you have adopted. I see you have involved nurses, nursing supervisors, housekeeping, but I honestly feel that one of the major component that should also have been part of your study would have been the family or the companion, because most often you will see in a ward setting, the nurses are not there with the patient 24 by 7, and it is their attendant, or the their companion who's with them most of the time. And I think if you involve them in education and prevention for falls, you will see a quite a good response in that,
Am I audible?
because I think most often we have seen that, even though the nurse is present with the patient, even despite being present, the patient and ends up falling. So this was one of the things that I wanted to see. Did you do something on educating the family members,
Yes, ma'am. Yes, ma'am. Am I
Dali?
audible, ma'am? Am I audible, ma'am?
Yeah, you are audible. Yes, you
Yes,
are.
ma'am. When it comes to patient attender, of course, we have involved, ma'am. Like when there is an alternative attender, what we have done, the education, the re-education, we made them. We have made a education to the alternative attender as well, ma'am. Most over for vulnerable patient than the nurse, we have involved the patient and patient attender by actually to say, ma'am, explaining the risk of a fall. If the patient have a fall, what are the risk and consequences will happen? That's way we have educated the attender as well as the patient, even the alternative attender, ma'am. That was the greatest thing where we could achieve a zero incident, ma'am, by involving the patient attender. That is one of our root cause also, where when there is an alternative attender, they were not
Very good.
focusing the health education. That's where we, for our first initiation is to educate the alternative attender by explaining the risk factor. If at all the patient have a fall, what are the consequences will happen, like prolonged hospitalization, even in terms of money, what they have to pay for extra 1 or 2 days. By this, we could reduce the zero incidence, ma'am, by involving the patient attender. You can hear me, ma'am?
Thank you, Dali, and thanks, Anu. With this, we come to the end of the presentations. And then I would now request my all jury members for 30 seconds comments or messages from them if you have any message for us, for all the audiences.
Hello, can you hear me?
Yeah, Dr. Mana, please. Yeah.
Yeah, good afternoon, dignitaries and delegates. I must express my gratitude to the Anicon 2022 for organizing such a wonderful conference. And I must share that I am so privileged to be the founder EC member because we are growing a lot in professionally. I am feeling great to be associated with the legend of nursing and growing under them. And talking about the quality improvement project, I must say that and salute to the ANI team for encouraging for the quality improvement project. And I'm anticipating for the coming year, many more such projects will come as because when we do our work by our own knowledge and information, if we found out some data, if we can incorporate to our profession, it will add to the body of knowledge. And I'm very sure the data, what we have found, if we can incorporate, if we can publish, if we can educate the world, and it will give us to occupy a powerful position and to lead the healthcare profession from the front. So I request all the members to remain very active in ANI. I also request non-members, once you enter, then you will understand how important it is to grow professionally. Thank you very much, Madhukari, for giving me the opportunity. Thank you.
Thanks, Dr. Unmana. Thank you. Can I have Dr. Anita, please?
Yeah, so compliments and congratulations to everybody. This is my first, I'm attending the first such conference. It was really enlightening for me to see how much work is being done through the nurses in the space of quality improvement and making a difference to the patient care. So I think there's really a need for the organization to drive it through and take it down to the tier 2 and tier 3 cities as well, involve more and more nurses to kind of get involved into driving these projects, because that's the nurses are the driver for the change in patient care and achieving excellence there. So I think, again, congratulations to everybody, and we really look forward to, and I personally actually would like to engage more in if it's possible in some which way, because it was very 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 good experience for me also to kind of see the kind of work being done all over.
Thanks, Dr. Anita. Thanks. Can I have Dr. Rosalind here to hear
Good
from you?
afternoon. Good afternoon to all. It is nice to hear all the presentations. From my assessment, I found that the preventive aspects and curative aspects were, the promotive part of two evidence-based projects which was presented, and also the preventive aspects in the quality improvement projects stands high, because without a project or without a research, we cannot speak to our administrators. So I encourage more research, more evidence-based research and data to be presented, so that that can improve the quality of nursing. Among all the other things, without a research, we cannot go forward. I appreciate all those who presented today, and more researches to come up. Thank you.
Very relevant point that has come up. Thanks, Dr. Rosalind. Can I have Dr. Anu Kaushik to spare your time for just 30 seconds message?
Sure, ma'am. I think I agree to everyone. The topics that have been chosen are so apt and so clinically important. I think, and especially overwhelmed to see the youngsters, who have, I was just trying to relate when I was of their age. Probably I did not have that kind of foresight. But good to see, and I think these youngsters will make good nursing leaders. Kudos to everyone. Keep it up. Thank you.
Thank you. Can I have Miss Binama Kurian to say something? Ms. Binama Kurian, please. If she's not there, yeah, fine. So thanks to jury members, all my jury members, to spare their valuable time for this session. And I'm sure that all of us, all the audiences, have really taken a message from all of you, very strong messages, and many good points for best practices to implement in their day-to-day practices from the presenters. I thank all of you for giving your time and for letting the nurses know about how the good practices and the research work can help keep on improving our daily practices. Thank you all. And thanks, Annie, for giving us this
Education
opportunity.
is an exceptional field. It's the only field where you have a possibility of impacting not only the lives of the individual today, but also making a change in the future. And when it comes to healthcare education, the possibility of impacting many lives, each of our students, each of the students who are going through a healthcare education context, the number of lives they impact really has a possibility of seeing the way India engages with healthcare, or the healthcare index of India gets impacted. And that is where all of us at Midvarsity enjoy working at and creating an impact on. At Midvarsity today, we are at an interesting tipping point. Not only do we have to look at how we're impacting education for doctors who graduated over the last 4 or 5 years, but we also have to prepare a curriculum and a set of courses and a methodology which will impact the millennials who are going to graduate over the next year or so. We continue to create value and impact on the ground. That is, save a life every day through every student that we graduate.